professor Paolo Bolognese. Dottore. Per chiari istituti che ci parlerà dell'instabilità craniocervicale e sindrome di Ehlers-Danlos.
Mi scuso in anticipo, siccome il mio glossario negli ultimi 20 anni sulla malformazione di chiari è unicamente in inglese, non voglio fare un buffone di me stesso, per cui parlerò in inglese. This contribution about craniocervical instability and Ehlers-Danlos syndrome. We started dealing with failed chiari surgeries that we recognized since 1995. What we define as failed chiari surgery are subjects with chiari 1 malformation who underwent a standard sub-occipital decompression, uncomplicated, with a good anatomical decompression on the MRI, but who were worse and disabled after surgery. So we were analyzing these patients who were kind of lost and pushed on the side, and the so-called lost patients. We were trying to understand which were the mechanisms causing this lack of optimal results. While we were considering and trying to sort him out of this complex file, we started seeing a subgroup of these patients who had some things in common. Some of them had incidents or clinical evidence of cranial settling and craniocervical instability. And more we're hearing from the patients, oh, I also have a diagnosis of Ehlers-Danlos syndrome. That most of them were tall, slender, thin, relatively young girls. So after hearing this more and more year after year, we decided, okay, maybe we should learn something about Ehlers-Danlos syndrome. So we got in touch with the national experts at the National Institute of Health, and were taught about it. So the Ehlers-Danlos syndrome is a group of connective tissue disorders which have in common a number of elements. One is the hyperelasticity and fragility of the skin, the hypermobility of the joints, which can be small joints, large joints, or both, the fragility of cutaneous blood vessels and large arteries, and poor wound healing. Per se, Ehlers-Danlos syndrome or syndromes are not a disease, are a condition. It's like being tall, being short, being black, being white. But if it is true that being short and fat leads you to a kind of a sort of number of risk factors, so you have higher chance of dying of a heart attack, at that point people who are hypermobile have a lot of more risk of subluxing their joints and so forth. Especially poor wound healing is a problem which can be easily understood to neurosurgeons and surgeons in general. There is a genetical defect underlying all the types of Ehlers-Danlos syndrome, and this genetic defect, which has been identified most of the types, is related to a deficient quality or quantity of collagen and a deficient or defective extracellular matrix. Particularly the cement keeping together your tissues altogether is defective. It's like having a house made of bad cement, like somehow this up when the mafia is part of it. Most forms are autosomal dominant. Not all of them are, but most of them are. This incidence is 1 per 5,000 individuals, which is incidentally the same kind of incidence which has been so far recognized for chiari 1 malformation. So two things in common. One is the incidence, and the other one is the fact that of both a disorder with a mesenchymal basis. These pictures are just put there, not because I understand it, but because I want to sound smart. And these are all the genetic defects which have been identified so far as the basis of most of the subtypes of Ehlers-Danlos. When I was in school, there were 13 kinds of identified types of Ehlers-Danlos syndrome, and that was not the first classification around. In the late 90s, they did another classification, and that's the flavor of the day. It goes from classical hypermobility, vascular, kyphoscoliosis, articulation, densitoparexis. The top 3 are the most frequent. The bottom 3 are the most rare. Classical and hypermobility are practically almost 90% of all the EDS types. If you put also the vascular in the middle, you cover 90% of them. Vascular has a bad prognosis because all the subjects tend to die before the age of 40 because of rupture aneurysms of the aorta. The diagnosis of EDS can be done, with genetical analysis in most of the subtypes, but for the most part, by rheumatologists and experts of connective tissue disorder, is done on the basis of clinical examination and family history. Since it's autosomal dominant, if you have your mother, grandmother, and a bunch of aunts who are subluxing, the shoulders and can sublux and command the hips, that pretty much gives the diagnosis. There's also some other piece of supplementary workup. You do an echocardiogram because 90% of these patients have mitral valve prolapse, and many of them have also other kind of defects in the heart. The MRI or the CT of the chest, abdomen, and pelvis is required because these patients can have dilations of the aorta in the thoracic or abdominal tract, or they can have varicosities around the ovaries. Bone densitometry is also important, especially if a patient undergoes an orthopedic operation, because this patient can undergo osteopenia or osteoporosis at a very young age, even in their early 20s. Skin biopsy is not the standard of care, but it's kind of a cherry on the cake that is done in certain patients in order to identify the genetic defect. It's not very cost effective, obviously, and once you have the clinical examination, the family history, the yield of these two together is very high. One of the mainstay of the diagnosis of Ehlers-Danlos syndrome is the Baton score, which is a score of articular hypermobility. It's just a pure convention, and if they could have picked any kind of joints in the body. What we have noticed over the years is that the joints that are listed over there in white, and with all the tests and the points you can get, are incidentally the joints you can study or investigate in a patient in an office without getting undressed. So the funny thing is that none of these tests checks for the three largest joints in the body, which are the femoral joint, the shoulder joint, and the craniocervical joint. So we're working together with the NIH experts in order to have a more comprehensive score, and then we're going to see how it goes. The range for the Baton score goes from 0 to 9. The threshold for hypermobility is actually recognized at 4 in many environments, but we were more conservative and we decided 5 to be our threshold in our studies. The higher the point, the more severe the hypermobility. 8 and 9 is extreme. All people who are contortionists in the circus, they're all Ehlers-Danlos syndrome. Obviously, certain sport activities like gymnastics, you have a natural selection for these people to be on top. So we were working on patients with failed KRE1 surgery, and we're discovering some of them, it was patient with EDS, and then we tried to reverse, and we tried to say, okay, there's a virgin patient coming through the door to our attention, let's see how many of these patients have EDS to begin with. So we started using all those diagnostic criteria. So after a number of years, after the first 4 years, we published a paper, but obviously the data collection still continued. What we have found so far is that 18% of the KRE patients seen at the KRE Institute so far have Ehlers-Danlos of other connective tissue disorders like Marfan syndrome, Stickler syndrome. But the interesting thing is that most of them have actually mixed features of 2 or more. 18%, we realized from the beginning, is probably artificially inflated from what's the reality in the average KRE patient, because there is effect of the referral patterns and the self-referral biases. So doctors will know that we are dealing with neurosurgical implication of Ehlers-Danlos are going to be more prone to send the patients to us or somewhere else, NIH included. And then there is a self-referral bias. If a patient, and again, these disorders are autosomal dominant, if a patient has a sister or an aunt, the ratio of female to male is 8 to 1 for most of them are women, who has the same problems and the same hypermobility, obviously they're going to come to us or they're going somewhere else. Support groups also play a role. Groups like ISMAC and IMAC have modeled themselves after the American groups for KRE1 malformation who first entered the field in the late 80s. KRE1 malformation in EDS, the number of cases in which, you remember before, the prevalence was 1 in 5,000. In order to have a prevalence of them combined, you multiply, and that you should expect this combination quite rarely. But the number of cases we're encountering, even taking into account the referral bias, was much, much, much higher, orders of magnitude higher than what could have been expected by chance alone. So we started looking at that more closely, so we realized that both the Chiari-Bauer malformation and EDS can affect the craniocervical junction and the medullocervical area, together or in isolation, with overlapping clinical presentation. In plain English. Chiari-Bauer malformation we know what it does. EDS can affect any joint in the body. And the distribution from patient to patient even within the same family is not homogeneous. So you have some patients who can just dislocate small joints, others who have spare small joints but big joints falling apart to the point they have to wear braces to keep them together, like tutors for the knees, otherwise they just fall off their legs at an early age, like during the teenage years. So since this is the third largest junction, largest articulation in the body, you can understand this can be hit as well. So an EDS patient with EDS-induced pathology of the craniocervical junction is going to have pretty much the same kind of mechanical stress than a Chiari-Bauer malformation would store. Practically they're hitting in the same area. Now, if a patient with Chiari also happens to have EDS and vice versa, or obviously 1 + 1 makes 3, the two things are compounding each other. The Chiari patient, then we started paying attention about the natural histories of these patients, and we're saying that people with Chiari can develop craniocervical instability in the absence of EDS after an excessive surgical bone removal or after severe whiplash injuries with or without the surgery. In the EDS patients, we saw that the same clinical picture could have been reproduced after even lesser severe and lesser degrees of whiplash injuries, or out to accelerating wear and tear of the craniocervical joints and ligaments. Everybody has a wear and tear in any part of the body, and obviously if you're already starting with ligaments which are suboptimal because they're made of defective material, the point is that the wear and tear becomes more pronounced. And then, other than the Chiari separate and EDS separate, we saw that there was a real subgroup of patients with both Chiari and EDS. And in these patients, the craniocervical instability mechanism was becoming more and more dramatic. Clinical features that we found was that the female to male ratio was 8 to 5 to 1. The average age was 10 years younger than Chiari-Bauer malformation alone. So were patients in their mid-20s. Most of them were tall and thin. The symptoms were evolving around lower brainstem symptoms. And very often when you have Chiari-Bauer malformation can hit you by compromising the cerebrospinal fluid flow and pressure, or with the big tonsils exerting a mass effect in the surrounding area. So we are finding more and more in these mixed Chiari EDS patients, more and more brainstem compression signs and symptoms. Radiographic findings, we found an interesting thing. What we defined as pandus formation, practically the retroodontoid ligament, was becoming much, much thicker than usual. Over the course of the years, since we've seen several thousands patients with Chiari-Bauer malformation, we had a clear impression that the retroodontoid ligament is a bit thicker in Chiari when compared to the normal population. But in this case, we're talking about 4 or 5 times over. Eagle syndrome and hypertrophy of the styloid process is something we're finding in almost 35 to 40% of them. The styloid process is a small process over here and connects some of your muscles to the voice box. And in this case, we had patients with saber-tooth dimension, like Zande Elefante, styloid process something 10, 15, 20 times bigger than normal, to the point that styloid process was reaching the carotid and compressing towards the middle side. All these patients were in a short mandible with overbite, high palate, nasal sinus abnormalities with recurrent sinusitis, and cervical spine instability of different kind we're going to see later. The diagnostic test we were exerting showed over and over, like in EDS patients, problems with mitral valve prolapse, patent foraminal valve, tricuspid valve resuscitation, and posterior orthostatic tachycardia syndrome that in many of these cases was secondary of a direct effect to the odontoid over the medulla. And all these patients had one thing in common, had a positive response to cervical traction and axial loading test. Practically, we push on the head with the patient sitting down, all the symptoms going overdrive. We pull them up and they want to marry us on the spot regardless of sex and religious orientation. Surgical complication of Chiari EDS when they are associated. There is obviously an increased risk of complication from posterior fossa decompression. Why? Because all the tissue we're dealing with is defective. So we have poor wound healing in the soft tissue. CSF leak because we're dealing with the dura that is very thin and very friable. Since the skin does not heal well, the risk of superficial deep infections is much higher. The risk of pseudomeningocele formation is extremely higher. Cerebellar ptosis, obviously, have tissues which are sagging. Cranial settling, we're going to see it, and craniocervical instability. We already talked about it. About the craniocervical instability, we suspect the diagnosis when we do the axial and the cervical extraction test. We're suspecting when we have the thick retroodontal ligament on the MRI. And we're suspecting when we have a patient with predominant symptoms and signs of brainstem, lower brainstem dysfunction. The definite diagnosis is done by invasive cervical traction coupled with morphometrics. We're going to go more on it. There are two kinds of, if we want to decompose the mechanism of craniocervical instability we find in these patients, we found the conventional horizontal instability with the plane to dental interval becoming much larger, something that you see over and over in the patient population after trauma. But in addition to that, we found a less understood, at least so far, mechanism, which is that of the craniocervical settling or vertical instability. Whenever we pass from the supine position to the standing or sitting position, the head sinks a little bit on top of the head, on top of the neck, and nothing more than 1 millimeter, 0.5. What happens in these patients is that you can have a settling which averages between 3 and 6 millimeters. And obviously what we have is a dynamic, if we want to exaggerate, it's like having a dynamic basilar invagination that occurs only when you are standing or sitting and disappears when you are supine, which is the position in which most of the MRIs are obtained nowadays, thus contributing to the history of this population of patients. So what happens is that in these patients there is the reduction of the basing to dense interval. We're going to see better in the pictures. There is no, all these problems are not linked to a bone or cartilage distraction. Obviously if you have an axial loading, somebody hits you on the head with a sledgehammer and breaks all the condyles, okay, obviously your head is going to be sinking on top of the neck. But in the absence of all that, in the absence of TB or cancer destroying the joint, you can have perfectly looking joint, but the ligaments keeping together in the synovial structures are defective and they collapse. And this is all only occurring in the upright position. The surgical implications are double. On one end, we want to prevent to push a patient from a frying pan to the fire. So if the patient with Chiari and EDS is not in trouble for EDS yet, we're going to be willing to, or at least we will try, to minimize the amount of decompression and minimize the disruption of ligaments and tissues and eventually do the extra cervical aneectomy. We always want to be comfortable. The less you do in this patient, the better it is. But if a patient already comes with Chiari induced symptoms and elements of instability, we know that no matter how minimalistic we're going to be, at that point we're going to have a patient with craniocervical instability, so we're going to have to tell the patient that most likely is going to end up needing a two-stage procedure, one for the Chiari and then one later on to address surgically the craniocervical instability. But since most of the component is going to be mixed vertical and horizontal, but most of the component is going to be vertical, the craniocervical fusion is not going to be done, okay, fuse you there like you are, but they stretch you up, and where you feel good, at that point, I fix you. Today, two names were repeated over and over. One is Dr. Milrat, who is my mentor, and the other one is Dr. Nishikawa. So Nishikawa is the guy who introduced morphometrics and the concept of volumetrically small posterior fossa in cave formation in the mid-90s. Very, very smart guy, brilliant guy, and like it happens with, in AC Milan and Inter, ci siamo comprati lo straniero. So we barely bought him from the University of Osaka. A very interesting story, because at the beginning it came with a grant of the University of Osaka to the Chiari Institute, because we had the largest database in the world about people with Chiari. And for us, for him, we were the candy store for the baby. So he was coming, he was having all these measurements. He was able to do it on a number of patients he would have used needed 3 or 4 lifetimes to reach. Once we saw what he was doing, and once we tried, we started understanding what were the implications, because we were having some needs. We said maybe that can help. At that point, we just hired him on the spot, and he never left since, with the regret of his wife. Everybody knows that Dr. Nishikawa and others who have copied his activity after him, they can measure the posterior cutaneous fossa volume and the brain volume, therefore demonstrating a mismatch between content and content, which is the base of the classic typical Chiari malformation. But what we do is to adopt many other morphometric data coming from tradition, plus what Dr. Nishikawa brought to the table, plus what we evolved along with Dr. Nishikawa for this specific problem, the craniocervical instability. So in a typical morphometric analysis, there are about 54 parameters which are measured, which are a combination of areas, volumes, distances, and angles. And in the past, these things were just done for scientific publication on very short case series. Since we have Dr. Nishikawa, we have the fortune of adopting this analysis on every patient step into the door. I'm one of the neurosurgeons there, and I see by myself 12 to 15 new patients per week without continued follow-ups. All Chiari and Chiari DDS and Chiari with their core, etc. So a while ago, we decided, okay, we know the patient is better when we pull the head up. Okay, the symptoms get better, okay, but that's kind of rough. It's not very scientific. So we decided to bring the patient to the operating room, insert cranial tongs, kind of Wells tongs, very simple and normal, and the profile for anesthesia, so it's more unique. And then taking x-rays under fluoroscopy while the patient is sitting, and then during craniocervical extraction applying 20 to 30 pounds. And then seeing what was happening to all the parameters of the morphometric analysis which were linked to the craniocervical junction. The craniocervical junction, the biomechanics can be decomposed in many different vectors. There are many different anatomical pieces. We're going to go very fast on it because otherwise it's going to take an hour just for that. These are some of the distances you guys are very comfortable with. Here the key is going to be the BDI, basic dense interval. Here we have a patient with a component of Ehlers-Danlos syndrome, supine to sitting to traction at 20, 25 to 30 pounds. You see that you go from 5.1 to 2.2, and the patient now is unhappy with a lot of symptoms. And then during traction, the symptoms are either improved or most of them go away altogether, and you have 5.7. So obviously, if you have a patient with supine and you do the MRI instead of an X-ray, you're going to miss this important piece of element, which is the pathology. In addition to the contraction of the BDI, there is also the basal to axis interval. Practically what happened is, because of the peculiar shape of the condyle and the articulation with C1, what happens is when these patients stand up or sit up, not only the head sinks on top of the neck, but also glides backwards. Therefore, there is a change of this interval from 3.1 to 7.2, and then back to 2.8 with traction with the reversal of the symptoms. These are some of the angles I was telling you above, and they're all angles between the clivus, the axis, and the odontoid. The angle that we have found the most helpful in order to understand the biomechanics of this group of patients is the so-called CXA. And again, from supine to sitting to traction. You have these two being patient is good. Patient is good this time strenuous or sitting, but during traction. So the gravity component and the laxity ligament is neutralized by the extraction. What we do at the time of this test, we ask the patient at the beginning of the test, before we even start anything, how many symptoms do you have today? There are 85 recognized symptoms of caries malformation, and we ask them, okay, out of all this, let's go down the list, and then you give us also a quantification out of 10 how severe it is today. And then we go down, and then we apply as much weight as up to a total max of 40 pounds, up to the point that the patient feels good. And at that point, we take the clinical snapshot and an X-ray snapshot. The clinical snapshot, we see how many of these patients, or many of these symptoms have resolved or improved, or some of them are non-responders. And then we have a positive result or a negative result or an equivocal. But I think which is the most important for us is the mapping of the sweet spot. The sweet spot is that spot during the traction at which the patient feels the best. Obviously, if I have a horse pulling my head and pulling too much, there's going to be a point in which I'm going to start being very uncomfortable. If I don't pull at all, I'm going to have all the signs and symptoms which are induced by the cranial settlement. So there is something in between those too much and too little, which is the sweet spot. And that sweet spot has a specific arrangement of angles and distances between the joints composing the craniocervical junction. So we can map it. So we can calculate, okay, when the patient is fine, supine, and then is upright, and then is upright with symptoms and upright with the cervical traction case, what is the BDI, what's the BAI, what's the CXA, what's the AXA, what's the CAA, what are all these parameters in the moment that the patient feels the best on the X-ray? And then what's the implication? The implication is that if the patient is sick enough to justify the risk of an operation, then the day after or a few days after, what we do is we bring him back to the operating room, we strap him on the bed in the prone position, and then we pull the head under X-ray control. And then we reproduce without waking up the patient and asking him, hey, how you doing? You feel, how's your headache now? Obviously, with the Mayfield and all modified clamps, we're going to pull the head and put it in the same position in reference to the neck that we knew already from the severe cervical traction that created all those benefits. So we can reproduce what we were seeking for down to the fraction of a millimeter. So we have a fluoro throughout the case, because throughout the case we want to be sure that that sweet spot is not lost because the Mayfield attachment slips or something else. And another, since we do a standard craniocervical fusion with instrumentation, we insert lateral masses at C3, C4, and we insert pedicle screws C2. Insert pedicle screws C2, do it today, do it tomorrow. That's one of these days you get the problem. So in order to avoid that, and especially to avoid problems of hitting the vertebra in these patients with very high variability in the anatomy of their pedicles, we introduced an intraoperative CT. So what we do, we pass a small C1 bit from the midas just through the first 2/3 of the base of C2. Then we leave the C1 bit in place on the right and on the left. We acquired a CT scan picture with the ISO C from Siemens. And then we get the three different orientation, the transverse plane and in the sagittal plane. The reason why the pictures look so dirty is that we prefer not to use the graphite adapter for the Mayfield, which would give a picture less fraught with artifact, because the graphite adapters and graphite holders have a give. So we tried a couple of times and then we just changed during the material during the operation. Graphite does not allow you to stay at the sweet spot and can make you lose terrain up to 2 to 3 millimeters. 2 to 3 millimeters in this patient makes a difference between feeling horrible and feeling very, very well. We prefer to stick with the stainless steel, and we get pictures that we can still see where the vertebra is and where is our C1 beat in reference to the potential dangerous path, and then we can do mid-path correction. The final end is just a conventional craniocervical fusion, nothing special about it. There are some tricks. One of the tricks is that many of these patients have osteoporosis early on. We learned the hard way. Usually we're doing DEXA scans on people on the cytometries on people who were 50, 60. Now we do it even in people who are in the teenage years. Take-home messages, and I'm finished. EDS and other connective tissue disorders are quite frequently associated with KRI1 malformation. So should be in the back of our mind. Obviously, if you never ask, if you never try to find out, you will never see it. It takes a second to say, okay, are you double jointed? Last component is the association of Ehlers-Danlos and KRI1 malformation increases the risk of cervical instability. That's the take-home message from today, as well as a number of other risk of EDS along, like CSF leaks and infections. Thank you.
Allora, ci sono domande, quindi iniziamo la discussione subito ogni dopo intervento. Posso farci una domanda io oppure volevo chiederti una cosa?
Ero quasi al sicuro.
Allora, la domanda, quando se hai studiato i potenziali vocali, quando metti in trazione i pazienti, se si osserva un miglioramento oppure se non pensi che non sia proprio inutile assolutamente.
Ok, ci sono diverse forme di potenziali vocati. Noi durante le nostre chirurgie usiamo i potenziali vocati sensoriali o per le posterior fossa decompressions e per le craniocervical fusions. Talvolta vediamo un miglioramento di amplitudini e un decrease of latencies, ma qualcosa come il 40% delle volte non c'è nessuna differenza.
Sono domande? Prego, Carmine Montolese.
Grazie per la tua presentazione.
Se non dai un microfono per cortesia. Grazie.
Quando parli di stabilità, quando tu parli di stabilità, C0, C1, C1, C2, e poi qual è il limite per te nei bambini di utilizzare delle tecniche con questi tipi di artrodesi metallici?
Okay. La prima risposta è semplice, come avevo menzionato prima, con le tecniche di Dr. Nishikawa possiamo distinguere le instabilità regionali tra C0, C1, C1, C2, C0, C2 e alcune volte c'è solo una parte della craniocervical junction che è coinvolta, altre volte è un coinvolgimento più globale, per cui può essere più di un vettore. Ovviamente per i bambini c'è un problema per inserire screws, so most of our patients fortunately are in the teenage or young adult series. Very rarely we had to deal with patients below 10. In those cases, obviously, you cannot use instrumentation.
Scusami, il problema è se tu hai un'instabilità della cerniera C0, C1, devi fare una fissazione occipito-cervicale.
Yeah, we go from the we put 4 screws in the occipital both sides.
If you have an instability of the craniovertebral joint at C0, C1, you have to stabilize the occipito with the spine.
Yes.
But if you have only C1, C2 instability, I think it's
No, C1, C2
mainly in children. It's not necessary to block
C1,
the
C2 you
oxygen.
just do either a wiring or you do a C1, C2 instrumentation. You have a C1, C2 isolated spine. What we have found in our patients is that the C0 to C1 component is the most common. That's why we are practically forced to do craniocervical fusions, occipital-cervical fusions in most of our patients. But occasionally we have found patients with just post-traumatic or EDS-related C1, C2. But most of these patients, for selection bias, they tend not to come to us, but they tend to stay locally with their pediatric neurosurgeon or spine neurosurgeon of their own state. Usually we have a selection bias because people who have these complex problems tend to come to us rather than somewhere else. So we see a higher incidence probably than anybody else of cranio-cervical instabilities because of the reason.
Avevo una domanda anch'io. Paolo, la cosa che volevo sapere, io da quando vi ho sentiti nel 2006 parlare di questa cosa ho cominciato a guardare con attenzione i pazienti e sicuramente nella popolazione italiana, nella nostra popolazione non vediamo una percentuale così alta come il 20% di instabilità. È perché vedete i casi falliti o c'è una degli altri centri oppure perché c'è una prevalenza, che so, razziale di questa patologia, qualcosa del genere? C'è una differenza razziale anche particolare?
This is very interesting. The first one is obviously being a quaternary center in failed cases tend to come to us. And because of all these reasons, people with EDS tend to have more chances to be failed than somebody else. Second thing, there is a referral bias instead of referral bias. We have NIH sending us patients like this, and the patients sending their family members to us. Race could be an issue. We have certain states in the United States where, like Pennsylvania, where the incidence of EDS is enormously high per 100,000 people when compared, for example, to other states which are neighboring. And Pennsylvania has a pretty homogeneous genetic makeup for certain areas which are up in the mountains. So yes, probably there is a genetic underneath. What was the second question for that?
Is there only one question for a referral or for lateral endosomal? Thank you very much.
Volevo chiedere che incidenza ha dannos la sindrome di Eagle, si chiama cefalea molto rara, e siete capitati di vedere pazienti sempre con la stessa sindrome affetta da sindrome da ipotensione intracranica spontanea, spontanea intracranica hypotension. A me è capitato di osservare una paziente con iperlassità legamentosa che aveva una ipotensione auricolare spontanea.
Okay, so there are two answers. One is about the Eagle syndrome, one is about the POTS, and then this should be the last answer, otherwise it takes too much time. The Eagle syndrome is when the hypertrophy of the stellar processes creates havoc inside either tracheoesophageal plane or compresses the jugular vein or the carotid artery. Shorter version of hypertrophy or longer version of hypertrophy which are more laterally positioned, they're not Eagles but just simple plain hypertrophy of the stellar processes. Out of all the patients we have seen over the years, we have seen very different degrees of hypertrophy, but we have seen only 3 real cases of Eagle which require surgical decompression of the stellar, which is a very invasive procedure. One of these patients ended up having a tracheostomy in place for 6 months. The gastroscopy was done by a head and neck surgeon. The other question, which is definitely hypertension, you can have the stellar process compressing the the barocenter innervation in the carotid, but very often we see that the hypotension, the posterior orthostatic tachycardia syndrome, and posterior hypotension in this patient is not due to this because the stellar processes are too short to reach that area, but they're due to a mechanism of dynamic compression of the posterior part of the odontoid on the interior part of the medulla. Obviously, it doesn't apply to all the patients with the EDS, but we find it quite frequent.
Ok, c'è un'altra domanda. Ringraziamo Paolo Bolognese per la bellissima presentazione.